อืม Hey, Marco. Hola, John.
Hola, Marco.
Buenos días.
¿Puede oírme?
Sí, te oigo.
Ok. Espera un
Puedes,
minuto. Un
puedes
minuto.
promover. Exacto.
Ok.
¿Puedes promoverme a panelista?
Sí, sí. Espera. Ok. Yuha está aquí. Wow. Qué bueno.
Yeah.
Yuha, ¿tú vas a encontrar Yuha ahora?
Well, el profesor Yuha, él me había dicho ayer que iba a hacer todo lo posible por estar acá.
Ok. Ok, Marco, su cámara.
Sama kysymys vähän tähän 1500 metriin liittyen. Kumpi on enemmän
Hola, Yuha.
vai pikkuveljen voittaminen?
I'm here, yeah.
Oh, good.
I'm here.
Yeah,
But
good.
I
Good.
just follow.
I've been speaking. I've been speaking in 15 minutes.
Okay, then I follow you.
Okay.
Good morning, Professor Yuha. It's an honor to have you here with us.
Good morning. Good evening here. Yeah.
Okay, great.
Tosissaan, kuinka paljon te sparraatte?
Now we have 15 minutes left.
Että varmasti saadaan siinä mielessä molemmat toisiltaan sitten paljon vinkkejä.
John, can you hear me? I spoke to one neurosurgeon that he did an online webinar too related to cystonostomy with Dr. Ipe, which is Savarish Natanjaran. And I told him that we were having today this webinar, and he was telling me that probably he will be here with us too. And also another neurosurgeon from Italy that he did also a cystonostomy conference like 2 years ago. And he was telling me that he probably will be here too. I can hear you. I can hear you, John. I can hear you.
Oh, that's good. That's good. It'll be free form. We'll see how it goes.
Okay.
Okay, I'll be back. Okay.
Okay, John.
Toni siinä herätteli kyllä vahvasti toiveita tuon ekaheton jälkeen, että kisaliitot, jos se sillä irrotaan, se kyllä Kuusella on aika kova vastapalli. Mauksi näette.
Vuotana on tehty aika isoja haukia. Onko ollut tekemässä niitä?
No, enpä juuri.
Lassi Etelätalo.
teitte nyt aika hyvin alaskyösten heittoja. Olette kolmantena 80. Sitten taas haluaa tulla kolmas heitto. Ja hyvä asento lähti kiertää matalana ja sitten kyntää kärki alas. Ei mitään. Ja se keihäs lähti kyntää liian aikaisin, kippas vähän. Ei tullut sitten mitään. Massi nyt vaatii pari tämmöistä välikierrosta ja sitten viimeisille kierroksilla Lassi viimeistään herää taisteluun voitosta.
Miesten 110 aitojen loppukilpailu. Ja alkuerissä nähtiin yllätys Santeri Kuusiniemi, Jyväskylän kenttäurheilijoiden mitaliehdokas, vahva mitaliehdokas ja jalkueri.
Joo, siellä tuli sen verran pahasti kolhimista, että ei päässyt sitten maaliin.
Kovinkaan monta ei käytännössä finaaliin kartittu, joten siinä kävi työtapaturma Kuusiniemelle. Asulahakinen Rauf ensimmäisessä Kalevan-kisojen finaalissa on 1. Jere Lehto ollut perintö 11 Kalevan-kisojen loppukilpailu. Ei mitaleita. Ilari Manninen on tosi vahvalla suosikki mitaleille. 4. ollut mitaleille aiemmin. Mitä sitten Pyry Santahuusta tekee Elmo Lakan vieressä? 14.44 parhaimmillaan tällä kaudella. Elmo Lakka, Jyväskylän kenttäurheilijat, herra ja hidalko 110 aidoissa. Tero Hirvinen ja Kankaanpään seutu Leivistuu, Joni Järvinen, Lahden Ahkera ja Juuso Peltola Jyväskylän kenttäurheilijat täydentävät tämän nivun.
Joo, tää oli 3 kauppaa oikeastaan ennakolta, mutta nyt Kuusiniemi jäi pois siitä, niin nyt siinä on sitten se 1 mitallisia jaossa ja tietenkin tämä nyt on herkkä laji, että mitä vaan voi sattua, mutta ennakolta Lakka vahvin ja Manninen siinä hyvin kannassa mukana ja sitten sielläkin onkin aika tiukkaa.
Seitsemänkertainen Kalevan kisojen 110 aitojen voittaja Elmo Lakka edelleen hyvässä. Rauf, Lehto, Manninen, Santahutta, Lakka, Hirvinen, Järvinen, Pelto. Ei tule suoraan juosta. Jas. Miehet ammutaan takaisin. Uusi yritys hetken kuluttua, mutta onko kaikki?
Katsotaan tuosta nyt ainakaan ihan heti. Saanut selkeästi näkyville, kuka siellä olisi mahdollisesti varat lähtöä, voiko vain epätasainen lähtö tai jotain muuta häikkää. Sitten keskiradalta.
Pyry Santahu.
Joo. Näyttäisi siltä ainakin tämän kuvan perusteella.
Joo, jos se TV-stäkin jo näkyy, kun jos ne hidastukset on kuitenkin hidastuksia aika tuhannesosia, niin voi olla kova paikka. Mutta edelleen monitoria tarkkaan. 0,1 sekuntia.
Jos on Pyry vähän katselee itsekin sinne siihen malliin. On vähän epäilyksiä herästä. Oli varmaan sen verran huomasi itsekin, tuli aika nopea aavistus siihen.
MM-kisojen aikana Tevan Allenin kohdalla nimenomaan 110 aidoissa paljon puhuttiin näistä, mutta punainen kortti, näin se on. Pyry Santautta, Kankaanpään seudulle leisti. Voi voi.
Ei tullut varmaan Pyrylle tuo yllätyksenä.
Mutta tulee varmasti pettymyksenä, oli mahdollista, että pääsi.
Kyllä, oli varmasti. Oli mitalli vielä ihan otettavissa.
Mutta Eero Hirvinenkin ottaa siinä ainakin Lakkaa näyttää, oli sitten Lakan lähtö huono.
Varmasti haluaa urheilija saada vielä vahvistuksen tälle.
Tämä on kyllä yksi urheilun julmimmista säännöistä mun mielestä. Ja ainahan se ei ole ollut.
Ei, se on ollut silleen, että on saanut kaikki ottaa yhden varata.
Joo, se oli melkoista showta joskus.
Joo, siinä oli vaan se, että se venyi monesti se startti niin paljon. 10 ottelussa on sääntönä, että saa ottaa yhden varata, niin sitten seuraavasti tulee punaista.
Kova paikka, mutta muut sulkevat nämä nyt mielestään ja keskittyvät seuraavaan läpi. Yksinäinen kaikuu Joensuun stadionilla. Raut Lehto Manninen, tyhjä rata, Lakka, Hirvinen, Järvinen, Pelto. Ja nyt päästään matkaan, ei jää muuta miehiä takaisin ajaa siellä ulkoradalla Juuso Peltola. Loppuun ensimmäisiin aitoihinsa. Lakka johtaa, mutta hyvän haasteen heittää Manninen. Manninen kolaa sen nyt aitaan. Lakka irtoaa siitä ja on menossa jälleen Suomen mestaruuteen. Jyväskylän kenttäurheilijoille kaksoisvoitto. Ja Eero Hirvinen Kankaanpään seudun leisku.
Hello, Manuel.
Hello,
Hello,
John.
Manuel.
How are you?
Good, how are you?
Hello, Diona.
Hola.
Hey, hola, ¿cómo estás? How are you?
Mira, él preguntó que cómo estás.
Okay, Manuel. Okay, this depends on you. Because we're gonna try something different, okay? It's not gonna be a straight translation, okay? I want you to kind of feel if it's something that needs the Spanish people to understand well, that you can stop it and say, let me explain this to them. And then you go and explain it.
Yes, perfect.
You know what I mean,
Perfect.
right?
Yes, absolutely.
Yeah, if you don't think it needs, a part needs translation, don't translate it.
Yes.
Okay, I said, have you heard from Ike?
No. I wrote him today morning. Only that.
Okay.
Marcos, ¿cómo
I
estás?
said once.
Hola, Manuel. Hola. Buen día.
Hola.
Buenas tardes por aquí.
Hola.
Buenas tardes por aquí.
Papá.
No, tú no necesitas.
Papá, ya no es eso. Papá,
Fernando,
Leral, dice, ¿cómo estás?
Bien.
Hey, Ike, you coming? Hey, Ike. Yeah, it depends on you. Okay. We're gonna try something different. It's not gonna be. Yeah, he's there.
And Professor Juha is here?
Yeah, he's here.
Hey, Professor Juha, how are you?
He may be just watching. Let me, what I want. I sent out the link to his WhatsApp.
I'm gonna write him now in WhatsApp.
Yeah, I just did. Okay, yeah, try it again. Hello, Noe. Did you get it okay, Noe? Oh, good. Marco, Noe, and Sylvia, Jesus, great.
How are you?
That's really all we need.
That's all.
Buenos días a todos. Good morning.
Hola, Sylvia.
Hola, ¿cómo están?
¿Cómo están?
Yeah, Marco, si alguien no entiende en las personas que hablan español, diga, espera, Marco, quiero hacer un pregunta. ¿Entiendes, Marco?
Okay. Actually, John,
Manuel,
Professor Ive is here. Professor Ive Shivian is here now.
déjame explicar, Manuel. Manuel va a arreglar el show. Él va a decidir si necesita traducción, si no. Okay? Oh, I've seen there, right?
Guys,
Hey,
hey, Manuel, we will join in. I will join in. Hari will be in place of me right now. I'm joining and I'm in the same room. I'm just joining in. Okay.
Okay.
Hello.
Should we wait for it?
Yes, like yes.
Oh, we got a minute. We got a minute.
Just do a few cases and then think of having.
Marco, this is a good start right here.
Hello, Manuel.
Yeah.
Yeah, where should we?
Good start. You guys will get some personal attention with UI and I.
Good morning to everyone.
Hello, Manuel.
¿Cómo te llamas, señor? What's your name? Standing in for Ike. I'm sorry, sir. What's your name? Habla español, inglés.
Arisi Palmar. My name is.
Okay, habla español or inglés?
No, English, John. English.
Okay. How can what's your name so I can introduce you? Well, I'll tell you what, I'll let Manuel do it. I'll just introduce you, Manuel. And you kind of, okay, Marco?
Yeah, no problem, yeah.
Okay, here we might as well start.
John, what would you think if we wait for the next maybe 5 minutes to see if everything...
yeah, I guess we can. Yeah, we can.
Set everything up?
Yeah, okay, we can do that. Yeah, Victor's coming in too. Victor's coming in.
Mikä on semmoinen oma yhteenveto sun hyppyistä tänään?
John, we have here Madeline too from Dr. Madeline. I think it is from I can't remember exactly the country.
Oh yeah, from not Czechoslovakia.
Yeah, exactly.
Not Poland. Oh man. Romania, I think.
Yeah, Romania. Yeah, exactly. Romania. Yeah. I invited her too.
Hello,
So she's
great, Madalena.
I'm so honored to be here. I'm sorry I can't join you with my camera on, but I'll be here and I'm so excited and can't wait for the presentation.
Yeah, Madalena is the head of the Walter Dandy in Romania. Welcome, Magdalena. And Jesus, how you doing today? Jesus Serrano Fuentes.
Hieno fiilis tuossa, kun ottelun saa läpi.
Okay.
Yes. Yes, okay. I'm here, Professor.
Okay, mira.
Today is a beautiful day.
Tú tienes preguntas de ahí. Díganos en español. Okay.
Yes, I speak a little English.
Sí, está bien. Tenemos un traductor, Manuel, para traducir cualquier pregunta que tú tienes, ¿ok? Diga, no entiendo esto. ¿Puede explicar esto? Y Manuel va a explicar. Okay. Manuel es muy raro. Es la única persona en el mundo que especializa en neurocirugía. Conoce inglés, español y cisternostomy. ¿Cuánta gente conoce estos tres? Inglés, cisternostomy, y Rusia y español. Nadie en el mundo.
Jätti vähän niin kuin ampaankolla jälleen kerran, että pikkasen lähtee epäonnistumaan molemmissa juoksussa ja tuli vähän kolhuja.
We have here the Dr. Victor Hugo's John. We have here. I'm going to promote him.
Oh, Victor's here. Okay.
Yeah, I promote him to.
Oh, good. You promote. Yeah, so you know how to promote and everything.
Yeah, of course. Yeah, I learned from you.
No, I thought you forgot or so. You didn't do it.
I learned from you, John.
Okay. How you doing, Noe?
Yes.
How are you guys?
Very good.
Hola.
There's Victor. Victor just slid the next chair next to you.
Hola, profesor.
You're the La Parte Mexicano.
Hola, un honor estar aquí para escuchar al gran pueblo hermano de Cuba. Yo tuve la oportunidad de estar 2 ocasiones allá con el doctor Javier Figueredo. Ya tiene a lo mejor unos 18 años por ahí, pero fue una experiencia muy grata. Felicidades por estos webinars. Un abrazo de México.
Bienvenidos,
Muchas gracias, profesor. Muchas gracias.
Janne Läspä. Ja mennään siis 4. kierrosta.
Víctor, ¿cómo estás? ¿Cómo te sientes?
Hola, qué gusto verte y escucharte ahorita aquí en las pláticas. ¿Cómo va todo?
Todo bien por aquí. Ahora mismo el clima está casi caribeño. Aquí, casi.
Qué bueno.
Casi.
10 ennätys ja ihan sinne samoille havinoille.
Polkyrinen heittää 76-87. Tästä on 6. Lähellä ollaan joo, Läspän ennätyslukemia.
Seuraava potentiaalinen 80 metriä yli.
John, creo que el profesor Yuja tiene su micrófono abierto. Y no lo sabe.
Emmanuel, ¿qué dice?
The Professor Junio has his microphone open, and he doesn't know it.
Oh, okay. Sí, okay. Turn the microphone on.
John, I was telling you that I invited Professor Savarish, which is a well-known neurosurgeon from India, which is currently working in US, in Massachusetts. And he has a very interesting work related to cystinostomy. I sent him the message yesterday. He told me that he was going to do his best to be here. And I hope he go through.
We ought to put him in touch with Manuel. That would be a valuable connection for him. Right, Manuel? From US, a neurosurgeon that does cystonostomy in Massachusetts, right?
We're gonna be fantastic. So I was talking to the guys, I think it was last week, Marco, when we had the talk.
About
cystostomy. Yes, 2 weeks ago, I think. And we was talking about the possibility to make a randomized multicenter trial, because this is the only thing missing. We need to make some randomized trials
Actually,
to see the results.
Actually, Manuel, he is conducting a randomized trial called CIS-TBI, cystonostomy TBI, and he's claiming for the people that are related to cystonostomy to message him and send him emails related to the patients they do the surgeries, and so he will be able to include all those patients in the trial. So maybe
that would be great.
I didn't know. Can you send me his mail? Because as I told you before, I have already 30 patients.
That's great. You can combine trials like that? You can combine?
Yeah, I am making one, John, right now, making a prospective study. And I have until now 30 documented patients who we perform cystonostomy.
Good. Very good. Is that going to be long? The gentleman that's, is that going to be long?
You can call me Hari, Dr. Hari. He is going to take some time. Before that, I will present a case for a short.
Oh, okay. Okay, he's going to take some time. He's going to be delayed. Okay, what do you want to do, Manuel?
Well,
Yeah,
the translator
there's a
is
common
saying,
thing in television. You got to fill time. Should we bring an old clip out?
John, also, do you know? Also, there is one of my ex-student here.
Where's that? In Russia?
No, was teaching in Dominicana, for example. She, her name is Andreina. She is very in, yeah, she's
really?
very in neurosurgery. That's very good. That's very good. I say to her, if you can choose very, very early what you want to do, like if you want to do neurosurgery and you choose very early and you are involved, it's going to be fantastic.
Yeah, sure. Look, we'll talk about it after, okay? I think we're going to be presented. This is Dr. Parmar. Is that your name?
Hello, yes, Hari Singh Parmar.
Okay, so I guess I'll introduce you, Manuel, and you introduce Dr. Parmar, and then Aip is going to come on after. What's going to happen?
Yeah, he is going to join shortly after my presentation.
Okay, great. That would be good for discussion. Okay, here we go. I'm gonna boot you off there a second, okay? To introduce myself and the channel. Right, here we go. Here we go. Okay, ready to start. Here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening. This is Dr. John Bennett. Or actually, good morning in Miami, from Miami Beach. This is John Bennett. We have an unusual webcast today. Basically, it revolves around cysteronostomy, and we've enlisted the service of the only person on the planet Earth that knows Russian, cysteronostomy, and English, and additionally Spanish. And this broadcast is essentially trying to bridge the gap between the language of Spanish and cysteronostomy. We feel that there are a good number of neurosurgeons in the Spanish-speaking world that want to know about cysteronostomy, but might get a better understanding if they had it translated, which Manuel is going to try to do. And we're not going to translate the whole thing. We're going to basically translate parts that he thinks that are essential for his Spanish-speaking neurosurgeons to understand. Is that confusing, Marco?
Yeah, it's okay. It's okay, John. I think it's okay. Actually, it's incredible to have the option of gather up all here today, and we have the amazing opportunity to have with Dr. Aip Shirian, which is one of the greatest professor ever related to school-based surgery, and he has brought one of the amazing topics in the last 15 years, which is mind-changing the idea and the perception of TBI. And is his amazing job, and what worldwide is actually talking about that. A lot of publications are related to that. A lot of trials has been conducted to that, and that's something that we Latin America cannot be a part of. And this is a huge opportunity to all of us. We also have here in the panel Professor Juha Hernes-Niemi, which is also an incredible opportunity. We will have soon maybe Professor Gerardo Guinto, which is going to meet up with us. Also Professor Victor Hugo from Mexico is here too. So the whole Latin American community is here essentially to listen this amazing job and to listen this perspective, which is something incredible. And this is a great opportunity to all of us. And thank you, John. Thank you, Manuel. And thank you, everyone, for being here.
Yeah,
okay,
Marco,
John, go ahead.
Thanks for getting the community. Gracias para traer la comunidad de español. Thanks for bringing the Spanish community. Now, let me turn it over to Manuel, who'll kind of run the program. Welcome, Manuel. Manuel is a neurosurgeon from Dominican Republic. He's in Russia doing his residency. He's very active on the internet. Okay, take it away, Manuel. It's all yours.
Thank you. Thank you very much, John. Thank you, Marco. First, thanks to everybody here, to all the participants, all the professors who are here. involved in this very pretty Sunday to talk about cystonostomy, some new technique to a coadjuvant technique for treatment of traumatic brain injury. It's a game-changing technique and it's came to stay. It's a fact. Lo digo en español también para todos los que hablan español aquí. Es importante esta técnica, ya hemos visto los resultados están hablando por sí solos. En el día de hoy estará el profesor Cherian, que fue el impulsor, el descubridor y quien describió la técnica por primera vez ya en 2007. Como el profesor Cherian dice, fue una serendipia. Una serendipia, claro, que ya tenía a sus espaldas un amplio conocimiento de la cirugía del trauma craneoencefálico y la cirugía de base de cráneo. En el día de hoy estará el profesor Cherian y estará doctor. Sorry, I have some problem with your last name, doctor here.
Harifi Parmar.
Gonna be talking in the beginning of Professor Cherian about cystonostomy. Do you know, doctor, I have some problem with the Hindi, and you know I was there, and I have some problem with Hindi. Do you know I was there, right?
Yeah, I know.
And my Hindi is very bad. But I apologize if I have some problem in saying your name or your last name. I beg your pardon.
You can call us Dr. Parmar, actually.
Dr. Farmani.
Yes. Could you please introduce yourself, Dr. Parmar, and where you work, etc.?
Yes, please.
Right now, my name is...
Primero de secundaria, nada más.
Can I share my screen?
Can you introduce yourself, please?
Yeah.
Doctor.
Share, na? Hello. Yeah, hello everybody.
Yes.
Myself Harifi Parmar, currently working as consultant in Krishna Institute of Medical Science, current with Dr. Ayub Cherian. So we have lots of experience with cystonostomy. I have done like more than 20 cystonostomy now. And it's amazing to tell everybody about this procedure. Each time when I do, I feel like doing it for the first time. That's how complex anatomy it is. So right now I'm going to present a case report of a patient, but just before that, I will show you, I will tell you something about basics of cystonostomy, what it is. Screen is not. Yeah. So what cystonostomy is, as per me? So it's just the opening of basal aortic systems and connecting it to the atmosphere. It's applying the same principles of microneurosurgery to access the base of skull. It has got same indication as hemicraniectomy. It seldom requires cranioplasty. Shunts are also most of the time not at all required. I have not seen any shunt, no collection, no encephalomalacia, and its benefited is physiological most of the time. So yeah. So this is a case of a scan of a 35-year-old male patient who came to our casualty with GCS score of 5T by 10. So the motor score was M3 and I response was E2. And he was intubated in the casualty, and after resuscitation, he was immediately taken to the surgery. So you can see the scan. The CP angle is widening, bitemporal contusions are there, with a bit of EDH was also there. You can see that. Uncal herniation and obliteration of basal cistern. For those who do ICP monitoring, you can see that it is almost all the cisterns are obliterated. So pressure is almost more than 20-25, almost. So as what hemicraniectomy indication is. So I will show you how we approach this patient. We go for frontotemporal craniotomy. Not bigger like decompressive craniectomy, but smaller than that. Approx 8 to 10 centimeter of craniotomy. Sorry, craniotomy. Yeah. So after craniotomy, the brain was very much tight. So due to huge cerebral edema, we have to go for axial unlocking in a form of we have to remove meningoorbital band Along with that, ACP drilling we have to do. So the strut has to be removed when the brain is very much tight. You can see this is frontal lobe, this is temporal lobe. We are doing it extradurally. Yeah. So this drilling has to be, ACP drilling has to be done whenever you encounter such tight brain, whenever there is a big cerebral edema is huge. So then we are using this needle holder to remove this ACP part after decoring the clinoid process. The sphenoid wing is decored, and this has to be removed by either nibbler or needle, whatever you are comfortable with. So this base of frontotemporal dura has been unlocked to gain some access to the cisterns over here, opticocarotid cisterns, and you can go through the Lilliefus membrane over there. So after this drilling and removal of clinoid, you have to be careful about cavernous sinus because it is situated just beneath it, and lateral wall will be very near to it. And about the two important structure, opticocarotid cisterns. Yeah. So after curving in a dural incision, you can see that ICA and optic nerve here. Optic nerve and ICA is here. So there's a lot of subarachnoid blood in between the spaces. So we are using suction over here to open this arachnoid. In trauma cases, yeah, it's sometimes it's very easy to open this membrane. Otherwise, you have to go with dissector and to dissect it, and then you have to give irrigation, a lot of irrigation actually, to remove this clothes from the this base of the tree. So now we are in the opticocarotid system. We have opened the system and getting out of the clothes. Yeah. This is the basilar artery now which we have encountered after clearing the cistern's blood and dissecting it with Lilliefus membrane is there. Yeah, this is the basilar artery with PCA may be encountered over here. Yeah. After this clearing of all this cisternal space, you have to put EVD drain. Right now we are using EVD drain. Previously we used to keep any feeding tube over that part. Yeah. Now you can see that brain is very much lax after this procedure. SSH and everything was there, but after this everything got settled. Brain also just sits in. This is the post-op scan of the same patient. You can see that this EDH we have removed it earlier only. After that we go for this hysterostomy and then followed by complete placement of bone over that area. So you can see that edema is reduced, hematoma is also not there. This is a video of sample. Few tips and tricks I would like to give. Whenever you encounter a tight brain, you have to go for ACP drilling. But before ACP drilling, meningo-orbital band has to be resected because it will not allow you to have proper exposure of anterior clinoid process. So meningo-orbital band resection followed by anterior clinoid process drilling has to be done. After anterior clinoid process drilling, only you will get more access to opticocarotid systems. And most of the time, you don't require, 90% of cases, you don't require to go for this drilling. It will be open after some sort of lateral skull base exposure only. Some zygomatic bone removal, after that you will be getting this zygomatic bone and sphenoid bone removal, you will be able to reach the systems. But whenever you encounter tight brain, you have to do this. But after dural, and another thing, after dural opening, you have to go fast for cisternal opening. Otherwise, brain will get more tense immediately. So you go for cisterns and open lily-phase membrane and put an EVD after irrigation properly. And when you after that, if you wash out everything and you keep, as per practice, what we do for drain is we keep drain for 5 days in most of the cases. But after 3 days, 3 to 4 days, you can remove. If you feel that CSF is getting cleared, no blood clots are there, brain is lax, patient is clinically well, is weaning off ventilator, so you can remove this and external drain also. Regarding instrument, you need to have 3 things for at least for doing this procedure. First is basic instrument, surgical instrument. I'm not talking about microscope or anything. First thing is you need to have big, long guarded section, at least 0.5 to 1 mm. Another is a fine dissector should be there. And third thing is Kamiyama or micro scissor, any micro scissor will do for cisternal opening. After this only you will get access to the base of brain. So you can go to pre-pontine cisterns and put an EVD and get it. Okay. Thank you.
Thank you very much. Dr. Manuel is here. Interesting
yes,
case.
I am here.
Okay, interesting case. I would like to ask something because I have read that there are a few differences in the technique to whether do the anterior clinoid process removal or not. So what are your thoughts related to that, sir?
Regarding anterior clinoid process removal. Hello?
Can you hear me?
Yeah, I'm not getting regarding what anterior clinoid process
Regarding
removal.
to the removal or of the anterior clinoid process, that's the normal standard of doing, or because I have seen that there are a few variations in the technique related to different publications. So do you consider all time doing the anterior clinoid process removal, or it just depends on the patient, depends on the surgery?
It depends on how tight the brain is, first of all, and how the scan is. If there is a gross diffuse edema and you are not able to open the system, that's what pre-operatively you sense from the scan and patient condition. And after craniotomy, you will get that sense that you have to open in this patient. At least till then, you will be confident enough that you have to go for this lateral skull base exposure more. Then it will be beneficial. You can open it without that also, but the thing is, it will be very much messy if you go for that directly. So systems opening will be good if you go for anterior clinoid process removal.
Yeah, what I can say is we have classified cystinostomy into type A, type B, and type C, depending on the difficulty of this. And as Harry just rightly said, most of the cystinostomies don't require an ACP. But
could you please move closer to the mic, please? Yeah, we can't hear you too good.
Can you hear me now?
Yeah,
can you
good
hear
now.
me?
It's good.
Yeah, so most of the cystinostomies don't require this ACP removal, but some of them when they are when the brain is really tight, then we have to do the sagittal and the axial unlocking. And removing ACP gives you that little extra bit of space where you can get into the systems much more easily. And plus you can mobilize the carotid a bit more easily so that the opticocarotid window and the carotico-oculomotor window becomes a bit more easier to open up. So that's the only reason. But I would say about 90% of cystinostomies, you wouldn't really require it.
You know, wife, we're going to try to incorporate the Spanish-speaking audience. Does anybody in the Spanish-speaking audience, ¿alguien tiene pregunta para hasta este punto en español?
I have one. Hello, Professor. How are you?
Hey, Manuel. Good to see you. I see you
What
also
you think,
is
Professor,
here.
also about flattering the superior the orbiter, the roof of the orbiter, if we flatter it with the drill, because
Yes,
as you always say, sometimes you have a very angry brain, like thinking go to the clino is a dream, because you roughly you can go to the orbitomeningeal band. Maybe if we can flatter it, we have much more space also.
See, one thing you must understand is it is not by retraction. Extradurally, it is not by retraction that you should get into the antideclinal process. It should be by cutting and opening the frontal and temporal lobes out. So even if the brain is very tight, once you cut and open, keep on opening it out, the antideclinal process will show itself. It needs a little bit of patience, but once you cut the orbitomeningeal band in the right plane, keep on dissecting the temporal lobe away from the pericavernous membrane. So see, the brain, the frontal lobe is like that, and then the temporal lobe is like that. So you keep opening it up like that, and then you will start seeing the ACP very, very clearly, even in the tightest of brains. But as you said, of course, flattening of the sphenoid ridge, including the orbital roof, is extremely important. And, you know, we estimated that you can remove about 30 ml of bone from the base. 30 ml, that's a huge amount. 30 ml of bone. Maybe Victor is here. Victor can also tell you some volumetric stuff. So you remove all that bone. You see, a tight brain, you remove 30 ml of bone from pressing onto that brain. That itself is a very significant thing. So you are thinking about only removing blood, CSF, all that. But once you remove all that bone extradurally, pushing onto the brain, then it's a step-by-step thing, you see. So you first remove the bone, so then the brain becomes a little bit more agreeable, and then you go ahead and remove the CSF. So this is the thing. So this is the secret to it. But on the other hand, if you do a simple tirianal craniotomy with no skull base work and you're trying to retract, we've done this. We have done this. So it's not a pleasant thing. These days, when the boys do it, it's much more pleasant, because after removing that amount of bone, it's much more easier.
Manuel, Jesus tiene una pregunta, si tú quieres contestarlo. Jesus, ¿tienes pregunta?
Sí. Yes, professor.
Español, para Manuel.
Yes, okay. Si la cisternostomía tiene las mismas indicaciones que la craniotomía descompresiva en el trauma craneoencefálico grave, me llama la atención en la etapa postoperatoria cómo se ve el flap óseo colocado. Si esto es porque la práctica de esta técnica, o sea, de la cisternostomía, permite un relajamiento cerebral que ya no sea necesario realizarle la marsupialización, por ejemplo, del flap en la craniotomía descompresiva y dejar el mismo flap en el mismo sitio. Era esa mi pregunta.
Well, yes, but first, if Professor Cheran is here, he's the, if Professor, he asked about if I can answer him, because he is my professor, and he asked about the in the cystonostomy we put back the bone flap, we put it back, and answering is if this is the reason of the cystonostomy relax the brain so much that we can put it back. So I don't know if you want to answer, Professor, or I answer.
Yeah, he is asking, what is the question that he is asking?
The question is, the main reason in the cystonostomy, we put back the bone flap So the reason is the meaning of the cystonostomy is one of the meaning of the cystonostomy is to put it back, the bone flap. The reason is we relax the brain so much. ¿Cierto, Jesús? La pregunta fue, el cerebro se relajaba después de la cystonostomía y podíamos recolocar el colgajo óseo, ¿no?
Yeah, the indications if are the same.
So if the indications are the same as the normal TBI hemicraniectomy.
If you ask me the indications for cystonostomy, they are almost the same as decompressive. So there's no difference. There's in diffuse cerebral edema, in cases where there is acute subdural, severe acute subdural, there are multiple contusions with severe brain swelling. All these are the indications for DC. They are the indications for cystonostomy also. The only difference is the timing. So in DC, you wait for the medical management to fail. And this is a standard protocol that you wait for the medical management to fail. And then once the medical management fails, you take up for DC. Now in cystonostomy, it's a proactive surgery, which means the patient comes to you. The patient has a certain radiological finding. So let's say the patient has a large acute subdural with, let's say, 220 millimeter shift to something, and there is impending herniation. So we know if there is impending herniation, there are some signs. So one of the signs is widened CP angle. The widened CP angle cistern is a sign of impending herniation, because what happens is the temporal lobe pushes the temporal lobe, the anterior part of the temporal lobe pushes the brainstem away. And this also, because the midbrain is pushed, the pons is also pushed, and that widens the CP angle. So we have published this. So impending, this is a impending herniation picture. So when you have an impending herniation picture, even if the patient's motor score is 5, we may have to go ahead with the surgery. So these are things, these are learned from our experience over the past 14 years. So we don't want to wait for the patient to deteriorate to M3 or M2 and then go in, or not wait for the medical management to fail. So we are going proactive, but indications are the same, but timing is different.
So let me try to translate, or Manuel, please translate to the answer to Dr. Jesus, so he will understand.
Yes. So, entonces, las indicaciones son las mismas. Son las mismas las indicaciones que la craniotomía descompresiva. La cystonotomía es una cirugía activa. En la craniotomía descompresiva esperamos que los protocolos los medicamentosos, que el mannitol, que la solución salina fallen. Luego de eso, entonces nos vamos, según como están descritos los protocolos, los estudios DECRA, Rescue ICP, y nos vamos a la craniotomía descompresiva. Ahora, en la cisternotomía, que es una técnica activa, porque lo que hacemos en la cisternotomía es que evitamos el mayor problema en el traumatismo. La causa secundaria, que es lo que nos mata el paciente, es el edema. Entonces lo que hacemos es que abrimos esa, vamos a decirlo así, esa llave, que es lo que va a provocar el edema, que ya lo habíamos explicado anteriormente a través de los espacios del Bishop-Robbins y de acoprina A4, del parénquima a la cisterna, lo abrimos, sale todo ese líquido, y por eso ese cerebro está bien, para decirlo en una palabra llana, bien blando, bien relajado. Y por eso es que podemos recolocar el colgajo óseo, dejándole el drenaje. Las indicaciones son las mismas, no las hacemos en un daño senal difuso, un paciente politraumatizado, eso no lo hacemos. ¿En qué las hacemos? En todo lo mismo que hacemos una craniotomía descompresiva, un subdural con una desviación de la línea media marcada, en contusiones cerebrales, en un hematoma intraparenquimatoso por igual, con una elevación del ICP, con una desviación de la línea media, etc. Espero haber respondido su pregunta, doctor Jesús.
Sí, cómo no. Muchas
We
gracias.
have another question from Dr. Suren. Profesor Suren, adelante.
Hola, buenos días. Bueno, muchas gracias, Marco, Manuel. Es un privilegio aquí tener al doctor Cherian con este tema, que él es el pionero en esta técnica, ¿no? Quisiera hacer unas preguntas, quizás ahí hablamos un poquito en la pasada sesión con Manuel, pero bueno, hay que aprovechar que está el doctor Cherian, que tiene una gran experiencia en este tipo de técnica quirúrgica. Mi pregunta es, bueno, en los casos de Manuel tiene alrededor de 30 casos y en todos recolocado el hueso. Igualmente, mi pregunta al doctor Cherian es, si él siempre, ¿qué % tiene en esta cirugía que recoloca el hueso? Y si es así, que es un % muy alto, la otra pregunta es, ¿qué craniotomía realiza? Si realiza una gran craniotomía de trauma o es suficiente, al ser una técnica básicamente base cráneo, es suficiente como hacer quizás una craniotomía terional más pequeña. Esa es mi primera pregunta, son varias preguntas. A ver, Manuel, si me puede hacer el favor de traducirle.
Sí, the question is, Professor, what kind, in which % you put it back, the bone flap? Which % of the whole cystonostomy when you made it? Also, what kind of craniotomy you performed? A huge 12/16, like a hemicraniectomy, or which kind of craniotomy do you use? This is the first question, the first 2 questions.
Interesting question. So this would be, I would say, was time bound in my journey of cystonostomy. First 300 cases that we did from about 2007 to maybe 2010 or even maybe 2011, we did not put the bone flap back. We just did the cystonostomy. We did not put the bone flap back because it was difficult to suddenly change 100 years of training, and it was difficult. So we did not put the bone flap back. After this, we started taking off a large bit of temporal bone and then put that flap back, started putting it. But these days, 99% of the cases, my consultants are here, both of them are, and Manuel has also seen in my unit. So we don't take out the bone flap, we keep the bone flap back. It has been a journey for me. It has not been easy, but it has been a journey for me. That is the first thing. Second thing is, we don't make as large as a craniotomy like in decompressive. We make a rather frontotemporal craniotomy with a lot of skull base work. What we do is we go right up to the temporal base and we drill off all the sphenoid ridge, and we drill all the way up to the superior orbital fissure, and then we try to open below. So this is the difference. I mean, that is true over the last 14, 15 years, we have come to this. So yeah, so this would kind of suffice. This would kind of show how we go ahead with the skull base removal. I mean, this is how we would go all the way up to the clinoid. Most often, we don't really go ahead and remove the clinoid, but in 10% cases, when type C, when 10% of cases we do, but otherwise there's no need. The difference is the brain, which is really, really tense at the end of a decompressive, so much so that it's unable to close. See, I know about cases where you do a subdural removal and the brain is even good in DC. We have all done these kind of cases. There's no much of difference in results in these kind of cases. They are good for both DC and cystonostomy. But there are cases in subdural or diffuse brain edema where the brain is really bulging out. It's really coming out. And these cases, once you open the cistern, it's like magic. So the second type of cases that I want to tell you about is severe brain swelling in cystonostomy and DC, and it comes down with cystonostomy. That is the second type of case. The first type of case is not much of brain edema. DC also no brain edema. Cystonostomy also no brain edema. Fantastic, no problem. Second group of cases are where you can address the brain swelling by open the cisterns, and then you are able to decrease that brain swelling and put the bone flap back. And these patients do excellent. Now, there are a third group of patients where this brain edema cannot be really addressed by DC or even by cystonostomy. These are generally patients whose GCS motor score is less than 2. There is a lot of infarction all around, and especially patients who had hypotension in the preoperative period. So these patients who had infarcted, there is even if you do cystonostomy, we have seen very few of these cases. We are trying to keep our ICU management. As the patient comes to us, we make sure there is no hypotension, no hypoxia. But if there is hypotension, gross hypotension, like in polytrauma patients, then we find that even with cystonostomy, it is not really useful. So this is the thing. So these are the 3 groups of patients. The maximum benefit comes for the second group of patients where CSF shift edema, because of CSF shift edema, you try and open the cisterns, the brain is, instead of brain bulging out, it becomes completely okay. Manuel, you are muted.
Reprendiendo la primera pregunta, el doctor Cherán decía que, igual como yo le dije la vez pasada, es muy difícil cambiar la mentalidad de las personas de una cirugía que se hace más de 100 años. Uno llegar y decirle, vamos a ponerle el hueso de nuevo. Todo el mundo dice, no, yo no le voy a poner el hueso de nuevo, eso es una locura. Bueno, el doctor decía que de las primeras 300 cisternostomías que hacía desde el 2007 a 2011, 2010-2011, no les recolocaba el colgajo óseo. Porque siempre ha estado el miedo de colocar el colgajo óseo. Es difícil. Pero ya recientemente a todos, un 99% de los pacientes se les recoloca el colgajo óseo. Y con referencia a la craniotomía, ya entonces se hace una craniotomía, hace una craniotomía más pequeña, una craniotomía temporal, no hace una craniotomía descompresiva clásica. De los pacientes que se benefician de la cisternostomía, lo que no están incluidos que se benefician de la cisternostomía están los pacientes politraumatizados, en que tienen una hipotensión marcada, que tienen un área de isquemia bien profusa, que incluso haciéndole la cisternostomía, estos pacientes no mejoran. Ahí están las dos primeras respuestas, creo.
Ok, muchas gracias. Bueno, más o menos, yo tengo una experiencia limitada en
Pero, doctor,
sí.
Respondiéndole algo, es lo que me ha pasado a mí, porque no tengo la misma experiencia de la pericia que el doctor Cherian. Yo aún prefiero hacer la craniectomía amplia, porque a veces tengo el miedo de que si la hago pequeña, me cueste más llegar a la base del cráneo y me cueste más abrir las cisternas. Y en ese tiempo que usted sabe que el tiempo apremia, el cerebro me puede salir afuera. Entonces, ese es el miedo que tengo, de que por la craniectomía, si la hago pequeña y no llego a la base del cráneo, por la falta de tiempo, entonces el edema subiendo y el cerebro entonces ya se va lastimando.
Ok, gracias. Yo tengo una experiencia limitada, alrededor de unos 9, 10 casos. Los primeros 2 casos no le puse el hueso, pero noté que efectivamente baja mucho el edema, la inflamación. Y los siguientes casos empecé a colocar el hueso, y los últimos que he hecho, sí he hecho la craniotomía mucho más pequeña, ¿no? No la craniotomía convencional del trauma. La segunda pregunta es, en los casos que convencionalmente nosotros hacemos una descompresión bifrontal, por ejemplo, pacientes con un edema difuso, ¿es también útil esta técnica de cisternostomía unilateral para estos pacientes que convencionalmente requieran una descompresión no unilateral, sino bifrontal? Si es útil, y si es útil, ¿por qué?
In the cases when we have patients with diffuse edema, diffuse contusions, and we need to make a bifrontal craniectomy, So what do you think if we can make a unilateral cystonostomy and we will have a good results, and why? What do you think about it?
So excellent question again, as usual. These are things which I get asked for the last 14 years. So I know the best questions when they come to me. So the answer is, if you have a large subdural on one side and a contusion on the other side, so I generally do cystonostomy on the side of the subdural, and then most often I leave the contusion on the other side as it is. But if it is really begging to be taken out, then I go with a very small very small craniotomy to take out the contusion, just let out, make an incision and just let out. I ask the anesthetist to give a Valsalva and it comes out. So this is what I do. In diffuse brain swelling, if there is no subdural on both sides, and I can do this with just unilateral cystonostomy. I can open the cistern on one side, both sides the pressure come down. But if there is real pathology on both sides, begging to be taken out, this is very important, begging to be taken out, not for the ICP, because ICP control, I can get it with the unilateral cystonostomy. Once I've done the cystonostomy, if there is a subdural also on the other side, then I would rather take it out. I would not. If there is an extradural on the other side, maybe I'll definitely go for it. Otherwise, in my last 14 years, or let us say last 10 years, the number of bilateral cases that we have to do is less than 1%.
Thank you, Professor. This is mind-changing, to be honest, because this is like changing the whole perspective that the world has related to TBI and the management. And because the way I see it, and the way when I was a resident, I was studying, most of the trials were conducted to wait to see, as you said, Professor, to see, okay, this is the first step where we see the patient, okay, the patient has a low GCS, and if it has an image related to the GCS, for example, acute subdural hematoma, or it has a midline shift or a multiple contusion with a temporal pulping. So that would be an indication for DC. Okay, that's what everyone used to do. But however, in the difference, once we have a patient with a GCS, but has a diffuseness of the brain edema. So that's the case of what we normally put into intense ICU care. So this is a very huge mind changing worldwide. And I think this is one of your amazing work. I think this is one of the greatest thing related to your job. And that's something I respect a lot, sir. That's honest. And we have another question from Mikhail Saleh. Mikhail, go ahead. Mikhail, because he has his hand raised, so well maybe he's not going to ask.
He's not what's the name again, Marco?
Mikhail, he's in here. I have a question, Professor. Is related to once you do the cysternostomy and you put the drainage in the prepontine cistern or the perimesencephalic cistern. Now, is it viable to measure the intracranial pressure related to the cistern, or would you prefer to go into the ventricular system and place an ICP, or don't put it at all? What's your thought related to that, sir?
Dr. Randall Chestnut and we don't get very well together because we advocate two different things. But Randall is somebody whom I respect a lot, and he's clearly shown that the role of ICP in the management of preoperative as well as perioperative management of head injuries is not really important as we think. Now, there are some exceptions. Of course, there are some exceptions. These are things that you should know. And with a cisternal drain, the only thing you can get is a trend. And Dr. Wang from Shaanxi, China, he's published papers also, and he's very clearly shown that he's put EVDs as well as a cistern drainage, and he's measured both. And he has shown that the cisternal pressure is a trend of the ICP, not really the ICP as we measure it with the ventricular system or with the ball, but it's a trend. When the cisternal pressure goes up, this means that the ICP is also going up. So you can measure the ICP trend with the cisternal drain. You cannot measure ICP, although. So it is there is a little bit of difference to it, but we never put in the EBD. We have never felt the need to. We always, by 48 hours, we are extubating. So we are not in a scenario where the patient is in complete coma and we don't know what's happening. We always extubate at 48. If we cannot, then we do a track, and then supposing the patient is very bad, already start with, then we do a track, and by the end of first week, he's on track. So then we see that whatever improvement comes is we not really looking at the ICP. I mean, we know there are some cases, as I told you, when there is infarction and there is damage, and we know that, you know, the brain is not going to do very well, then it is not really on the ICP trend. Unlike DC, we're not really worried about ICP going up. Once you see this thing draining almost 300 ml every day, then your ICP is going to be, I mean, even if you take a scan, you will see that the ICP is never going to be a real problem. And the thing is, the best thing is to come, like Manuel has been here with us. So, and now all the other fellows, so you have to come and see it. You come and see it, and then it is the best way to move forward. Because a lot of the people who started cystonostomy trials, like Roy in Switzerland, the Italian chaps, all of them, the Chinese, all of them came here and they were completely against it, because of course we have 100 years of teaching saying that we must do a DC in these kind of cases. So when they came and they saw, then they started trials. And I think this is the way to go. We would invite each one of you to come, see how it is done, and then you will be able to figure out how it's done. Now, Manuel has started doing it. So Manuel came, stayed with us maybe for 1 year, and then he started doing it. So I'm sure all the other fellows also who are with us will be able to. It's not a rocket science. It's not a very difficult procedure. It's something that you have to do every day in and out in skull base and vascular procedures. So this is the need of the hour also, that you should get trained in these kind of procedures too.
Thank you. We have another question from Professor Sur Matutes. Aran, go ahead.
Gracias, Marco. En realidad me han quedado dos preguntas. Bueno, una es sobre esto que hablaron del drenaje ventricular. En los últimos casos yo he hecho algo que aprendí con el doctor Yujas en Niemi, que es colocar un catéter a través de abrir la lámina terminal y colocar un catéter en el tercer ventrículo. Me gustaría saber la opinión del doctor Chirian acerca de eso. Y la última pregunta es, ¿qué importancia le da cuando hace la técnica de la cisternostomía a las contusiones temporales? Si también dentro del manejo hace la resección de la contusión siempre o cuándo lo realiza, ¿no? Serían las dos preguntas.
So the question is, Professor, when you have a temporal contusions, what you do in that cases? Do you remove the contusion itself? And the second one is, he also sometimes he opened the lamina terminalis and then go through the third ventricle. So what you think about it? Doctor Surin, eso es para medir la ICP, ¿verdad? Que usted lo hace.
Para drenaje y medir la presión arterial. Yeah, para los dos.
With the catheter.
Again, Dr. Suren, where are you from? I mean, you are asking very good questions.
Mexico.
I see. I am coming there in November.
Hermosillo, in the north of Mexico.
Yeah, I am coming there in November. I hope I can be seeing you there in November.
I see you first time in the Dandy meeting in 2012 in San Luis, and you talked about the cystostomy.
Yes. I used to come there as faculty in that is 10 years back. I used to. So that was a course that I enjoyed. Salim is my very good friend. So we had Jack Marcos and all those guys coming there, and it was fun. So I was going there to 2015, but then the travel is too much. It's for us, it is another completely the opposite side of the world. So it is difficult. But yes, I would love to go again. When Salim restarts his courses, I would like to go again. So I probably, you remember me talking about cystostomy that time.
Yes, I remember. What was the first time that I see you are talk about cystostomy?
Yes. Yeah, so your questions, coming back to them. So if there is a large temporal contusion, yes, of course I remove it, because this is a risk. Even if after doing cystostomy, this is a risk that the temporal lobe can herniate in the later stage because of cytotoxic edema, and this completely changes the picture, because herniation happens. You are having a temporal lobe which is going into a space, into a very small room where the brainstem is and the tentorial notch is, and then you suddenly have the temporal lobe going into that place, then that really screws up with everything, and that produces the low GCS. Brainstem compression produces low GCS, produces a lot of problems. So I will not have any doubt if there is a large temporal contusion. This is something, it's a very important question from Suren. So I go ahead and remove the temporal lobe. There is no question. Now we have even started something called unherniating. This is a paper that we are writing up. What we do is we take a retractor. After I removed a little bit of temporal lobe, we take a retractor and then we pull the temporal lobe up so that we unherniate the temporal lobe. This is very interesting, and it is extremely important, because the herniated part of the temporal lobe, people say it's dead and it is you cannot do anything. Sometimes this temporal lobe goes up to the carotid. Forget the third nerve. People say they go up to the third nerve, but many of my cases I see the temporal lobe over the carotid. It is so badly herniated that it crosses over the oculomotor, comes to the carotid. It's not much of a distance, you see, and it will be over the carotid. So what we do is we put in a retractor gently and pull up the temporal tip gently, and we call it unherniation. Both my consultants are very familiar with this term. So if we cannot unherniate, then we remove subpially that part of the temporal lobe. And this decompression of the brainstem is extremely important. This is one thing. The second question that he asked was whether I open lamina terminalis. Now, we used to open this. In fact, Juha will tell you, Juha was there with me from 2017 to 2018. And at that time, when Juha was doing it, he advised us to do lamina terminalis. We were opening it. But what we found later on, that we found that when there is no ventricular blood, doing this will be introducing cisternal blood into the ventricle, and your incidence of post-operative hydrocephalus goes up. So we stopped doing that. So earlier, yes, and it really helps to sometimes to get a little bit more of brain relaxation. It helps. But then opening all the cisterns, and if there's no intraventricular blood, we don't open lamina terminalis anymore.
Thank you very much.
Incredible. We have here Professor Juha. Will it be possible from Professor Juha to have his thoughts related to this subject?
Juha, are you there?
I'm not sure he's in the panel. I tried to get him in, but
Oh, it looks like he's out. So we have another
perhaps he
question.
stepped away. Perhaps he stepped away. There's a Mikhail Sally that has a question.
Yes, we have a question from Mikhail Sale. Mikhail?
Go ahead, Mikhail. Oh, big chance, Mikhail.
Oi, Marco.
Hello, Mikhail.
Oh, there we go. Great,
Oi.
great.
Todo bien, Marco. Muchas gracias por la invitación. Muchas gracias. Mira, yo tengo 3 cuestiones muy sencillas. Yo todavía soy recién graduado y todavía estoy aprendiendo bastante con este tema, que es muy interesante. La primera cuestión es si existen algunas indicaciones específicas de asociar la cisternostomía con una DBE, o sea, si existen casos muy específicos y puntuales para asociar estas 2 técnicas. Y la otra cuestión es si existen también particularidades anatómicas, incluso indicaciones para los pacientes pediátricos para hacer esta técnica. Y bueno, la última es si hay alguna experiencia de esta técnica en pacientes con infarto maligno de la cerebral media, donde uno hace la cranectomía descomprensiva y si hay algún relato, si hay casos que el profesor utilice esa técnica también. Son tres cuestiones.
One more thing, Manuel. There is a person called Noah Perez Carrillo. Noah Perez Carrillo. He's written to me that he would like to invite me to give a class in the course. I think is about the time when I come to Mexico. So I would be most happy. I didn't see the message, but I would be most happy. October last week after Shanghai, I'm flying directly from Shanghai to Mexico, and I should be there for a week. I should be there from October last, maybe 30th to November 5th or something, because 6th I have to fly to Nairobi. So it will be a very long.
Professor, you're going to be here in October, remember? School base in Tumen.
Yes, Albert's course, of course. I cannot.
Yes, of course.
I cannot say no to this for sure. So Albert will murder me otherwise. Yes, I will be there. I have to please get the dates for me, Manuel. Please, I'll talk to Albert.
Yes.
And then I will be there.
Yes.
But November I will be there in Mexico, because this is something that I have been putting delayed for some time. But my good friend Victor, who was supposed to be there, ditched me at the last moment, and he's going to Athens, I suppose. But I would have very much liked Victor to be there, but of course, if he has to go to Athens, yes, otherwise, but I'm looking forward to visiting Mexico for sure.
Yeah, we do a regular webcast like with Dr. Noe every Thursday night. So I don't know if you want to call. We'll put you in touch with him. Okay, go on. Okay, Manuel.
About the answering the question of Dr. Mikhail. ¿De dónde es usted, Mikhail?
De Mozambique.
Mikhail, Mozambique. Yo soy
¿De
de
dónde?
Mozambique.
Mozambique.
De Mozambique. Wow. Wow, qué nice. ¿Estás en dónde? ¿En Venezuela?
Brasil. Está en Brasil.
No, estoy en Brasil.
Oh, excelente. Okay, so, Professor, he wants to know about the experience in pediatric patient. That's one. That's one of the question. The other question was
I didn't get
Michael, first, can you respond about this question? I'm gonna ask Michael the other 2 questions. The experience in pediatric patients.
Yes. Well, in pediatrics, we've had a series of, till when we stopped counting, we had a series of about 50, and we always want to publish this data. So in pediatric cases, mostly it is diffuse brain swelling. It's not acute subdural or contusions or anything. It's diffuse, very bad brain swelling. And these patients do exceptionally well. Once we open the cisterns, and the good thing about these patients are your school perform. We have a lot of these Facebook friends. These are children who have been operated for these, and in the first few days we lose hope. When the brain just starts coming out, we lose hope, but a little bit of retraction and you reach the cisterns and you open these cisterns, it's magic. So pediatric patients, it's difficult, way more difficult during the perioperative period and during the intra-op time, but believe me, they will have a life. I mean, with DC, what happens is they come out and then they live like idiots for the rest of their life. But I can show you cases where these children go on to have similar kind of school performances and life after this, because over the last 15 years we've seen that this is one of the places I will stoutly really beg you to consider this. Although it is difficult, I would really ask you to consider this instead of DC.
Michael, the other two questions, can you repeat it, please?
Te puedo hablar en español, no tiene problema. Mira, la segunda cuestión, cuestión es si hay alguna experiencia en estos casos de la cisternostomía, donde el profesor, en caso del paciente con infartos malignos de cerebral medio, donde uno a veces tiene que hacer la conectomía descompresiva. Si en estas situaciones también él asocia esta técnica de la cisternostomía. Y la última cuestión es solo para saber cuáles son los casos específicos que él asocia la cisternostomía con la derivación ventricular al exterior. Si existen relatos de estos casos.
No entiendo esa última. ¿Una relación con la derivación ventricular?
Si hay casos donde específico o hay indicaciones específicas donde uno tiene que asociar la cisternostomía con una derivación al exterior. Si existen casos, indicaciones específicas. O eso depende de la situación del momento. No sé si me entiende la cuestión.
Sí, te entiendo, pero es que porque hay una diferencia de líquido tanto en la cisterna como en los ventrículos. Porque entre las cisternas están los espacios de Virchow-Robbins y los canales de acuoporina que no están en los ventrículos. Por eso es que aunque hagamos la ventriculostomía, no es lo mismo y el cerebro no se relaja igual. Pero yo hago la pregunta al profesor. So his question is about the in the cases when we have infarct, professor, a huge ischemia, if we can make the cisternostomy. Also, and in the cases when that's one question, and the other question is if we have a ventriculoperitoneal case, or if we can make it. ¿Cierto, Michael? Si podemos hacerlo
una derivación al exterior. No. Sí, hay indicaciones.
Un EVD.
Un paciente. Un EVD.
And also if we can make an EVD for like a cisternostomy. If we can make the EVD and it's going to help.
Okay, the first question, I don't have any experience in malignant infarcts because I did about 12 of them when I was in Kerala and in Nepal when I started this in 2007, and in 2008, 2009, we did about 12 or 13 of these, but I would say about 80% of these cases I had to go and take the bone back out. I mean, or maybe do a much bigger craniotomy, and then maybe my experience with this malignant cerebral infarction was very bad. So I wouldn't recommend, but the Italian group has started doing cisternostomy in patients where the malignant brain's edema, cytotoxic edema has not set in. The window for the mechanical thrombectomy is over, but malignant cerebral edema has not started. So this specific group of patients, the Italian group, Massimo Cardali's group, has now just published in World Neurosurgery. They got excellent results. So I don't have any experience, so I cannot comment. I don't know. Second thing, an EVD comparable to cisternal drain is not correct, because you must understand, if you understand the CSF dynamics, the ventricular CSF is a production phase. So what happens is you have these ventricular CSF does not communicate with the parenchyma. There is no channels of communication for this ventricular lateral, third and fourth ventricular CSF to communicate with the parenchyma. There are no direct channels. But in the cistern, these CSF is in direct communication with the brain all the time. Huge communication with the brain, because through the Varsha-Robin channels. So through Varsha-Robin channels, these CSF is being pumped in all the time into the brain, and they have huge two-way communication. So it is like you take two balloons which are communicating, and you put a hole in one balloon, and the other balloon also starts collapsing because they're communicating. If you take two separate balloons which are sitting close together and you put a hole in one balloon, the other balloon does not collapse, you see. So this is the difference. If it is like two balloons which are communicating, when you open the cistern, the one balloon which is communicating with cisterns are the balloon, I will say cisterns and the brain is like communicating. So this CSF which has gone in from the cisterns is what we termed as CSF shift edema. We describe this term CSF shift edema. So this is the difference. So EVD can never, EVD plays only with the compliance. What is compliance? When you inject, let us say, take a Coke bottle, 1.5 liter Coke bottle, and inject 100 ml of water into it. After you inject about 2 or 3 ml, let us say you inject 5 ml, and then the pressure you need to inject the rest is huge. And you take out 2 ml, the pressure goes down completely. So this is the difference. So you're just playing with compliance. When you take out in a very tight brain, when you take out EVD 2 ml or 3 ml, you're just playing with compliance, nothing else. You're not communicating with the parenchyma. On the other hand, cisternal CSF drainage really is communicating. You take out the cisternal CSF, on the table you can see the brain getting lax. I mean, it's not something that you have to wait for or something. You take out, you open the cistern, you wash out all the blood, and you can start seeing the brain getting lax.
Thank you, Professor. So, Professor, would you say that with this statement that the pressure inside the ventricles tend not to be higher than the one in the cistern in TBI?
No. This is not what I
So
said.
If the pressure inside the ventricle, because the CSF doesn't have the amount of communication with the cisternal space,
Yes. So if you inject markers into the ventricle, there is this beautiful experiment where they injected markers into the ventricle and markers into the cistern. The ventricular markers, even after half an hour, the ventricular markers never reached the parenchyma, while the cisternal markers in half an hour was all over the parenchyma. So the communication is huge between cisternal CSF and parenchyma, while ventricular CSF versus parenchyma, almost no communication.
So because what we have noticed is once we have severe TBI and we decide to put a catheter inside the ventricle and we release CSF, the way that the brain relaxes is not the same that once you do the cisternostomy.
Yes, completely. It is because there is no communication. You are just playing with the compliance only. The other one, you are really communicating. That is why I said the example of two balloons in a closed space. the two balloons are there, they are not communicating. If you drain one, if you put a hole in one balloon, the other balloon gets some space to relax, but the other balloon is not going to, it is not going to decompress. But if you have two balloons which are communicating, if there is a way to communicate, say, let us say there is a channel between, and you put a hole in one of them, both of them will decompress completely, you see. This is the difference, because this is something that a lot of people in the world does not understand. This is why CSF, the paper of CSF shift edema that we described, is extremely important, because these two compartments, cistern and parenchyma, they're communicating all the time. And this is for cooling and cleaning. We also described that. It is in Springer Nature, the textbook. We have the chapter in this, and then we described it. We described how this cisternal communication helps in cooling and cleaning of the brain.
Okay, we have a question from Dr. McIntosh, which is in Cuba right now. He's asking if the cisternostomy needs to be do only in the interpeduncular system, that if what he asking is it's necessary, needed to open the Liliequist membrane, and if it's possible to do it in a different cistern, because what he is saying that is, and somehow is so difficult to see deep down once you don't have, for example, magnification with a microscope. And in case of you don't have the magnification system, which other system would you be able to use? That's his question, essentially.
Well, without a microscope, opening the Liliequist is something I would be worried about. I mean, I have now over 2,000 cisternostomies, and I would never advise anybody. I mean, if I open, I'm sure I can get into serious problems if without seeing it is a blind procedure. I may be lucky, I may be, because I know the direction of perforators, I know the direction of vessels, I may be able to just get out with it, but it is something that I will never ever advise. So you need a microscope, but I believe that better than the microscope, because we have the and we also have the exoscope now, and I believe now the exoscope is going to be the future, because it's a digital image, and it is, you don't have to be married to the microscope like the oculars all the time. So you can have a different angle and you can sit and beautifully operate. So I believe this is the future. So, and different exoscopes, Manuel has made one. So it is not 3D, but it's a 3D exoscope, a cheap 3D exoscope is the answer, and is the future. We are working on it right now, and the way we have seen the future of exoscope. I was in Europe to see, check out all the exoscope with some prototype testing and all that. I saw the Orba in Prague, and then in Germany we saw the future of the exoscope is definitely, this is the future. So magnification devices, yes, for sure. You should, as youngsters, you should not even think of going back to the era of no microscopy or no magnification. I always tell everybody, if you don't have a microscope, sell your car, sell your house, live in a tent and get your microscope, or get whatever is required. It's without it, you are going back to the dark era, and it's not good. It's definitely not good. So anybody tells you that you don't have resources. I was in Nepal and we had no resources at all, but I got my microscope. It was my first priority. I got a microscope first thing. I begged, borrowed, I did everything possible, but I got my microscope, and I don't regret it. 15 years back when I got it, it was tough, but I got it. And Nepal, nothing was there. There were 7 neurosurgeons at that time. But now, if I had not got my microscope and I said I was resource limited at that time, today I will not be doing anything. I will still be comfortable in that non-microscopic era. So as your age comes to, 40 and 45 and all that, you tend to be, you lose the Viking spirit, which means you don't want to You don't want to get into situations where you can die, where you can be hurt, where you get old and you don't want to do new things. So before you lose your Viking spirit, get your microscope, sell everything you have and get your microscope or your exoscope, even better, get a beautiful exoscope and then start operating. See, at my age, it was very difficult for me to start operating big cases with exoscope because I had 20 years, I'm used to microscope, I have the Kinevo. Why on earth I should operate on something which is completely strange? But I wanted to make sure my Viking spirit is not dead. I started operating with it. Now I'm comfortable, you see. So to adapt to future, don't listen to all the old people, including me. If I say it doesn't work in infarction, you go and prove me wrong. This is how. If I tell you something, this is unclippable, go and prove me wrong. This is the spirit of progress, Viking spirit, okay? Go ahead and do it, all right? So never ever go back to an era with no microscope. Don't accept it. Don't accept. Sell everything you have. I'm telling you, steal a bank, okay? Go get it.
Thank you, Professor. We have a comment from Duniel, Profesor Duniel. Un placer tenerlo acá. Profesor Duniel, parece que no va a ser. El profesor Víctor Hugo quiere hacer algún comentario, profesor. Un placer tenerlo acá con nosotros. Un honor.
Congratulations, dear friend Ike Sherian. I think your technique right now is worldwide known. That is a very great job. I've had the honor to be with you several occasions in Nepal. I have seen your techniques, and I think in a few years more, this technique is going to be realized worldwide. I don't have doubt about that. So congrats. Another thing is that because Manuel told us that you are going to come here in Mexico, I want to add that this commitment was taken several years ago. So thank you. That's it.
I'm looking forward, dear Victor, to see you in Nairobi and maybe after that many times more, maybe in India too. So let us see what happens.
Yeah, we'll be there. Thank you so much.
Thank you. Thank you, Professor Victor Hugo. Professor, I have, there are a lot of questions regarding to the cystonostomy because it's huge and it's an amazing job. And for example, related to the complications, because we know that the compressive craniectomy, one of the main complications, first of all, the subdural hygroma, the subdural effusion, and the other one is the hydrocephalus. However, in the cystonostomy, essentially what we do is we open up the basal cistern. So we allow the CSF to go out. So it's not a common complication related to cystonostomy, the subdural effusion after the surgery, or is or isn't in your experience?
Yeah, so when you talk about the complications of cystonostomy, it's a completely different thing. First of all, it is related to your learning curve. Where are you in terms of the learning curve of cystonostomy? Because as for me, when I started and over the next 14 years, I had many complications. You can think of all the complications that can happen in cystonostomy has happened to me. So I've had vessel rupture, I've had severe, uncontrolled brain edema. I have had everything. So, but now I know what to expect, what not to expect. Obviously, this is not a miracle, but I can still tell you it is way, way better than decompressive. It is any day much, much better than decompressive. But complications can be listed into one, vascular complications. If you don't know in the opticocarotid window where you are going, and you can damage perforators, sometimes even damage PCOM. But once you know, if you are a vascular surgeon, these complications are much less. But if you are a resident starting to operate on cisterns first, you can have these kind of complications. This is the first thing. The second, chronic complications, as one thing that I have seen was postoperative hydrocephalus. When we stopped opening the membrane of, the laminar terminalis, it reduced considerably. But yes, sometimes we have sometimes infections, very bad infections with the meningitis and ventriculitis. This is also there, but again, it's a matter of taking care. It's a matter of theater sterility. You ramp up the theater sterility, and you make sure that your surroundings are, your procedure is watertight. You don't have any ways of getting infections. Then these kind of things can be avoided. Yes, sometimes one of the things we have seen is over drainage. Over drainage is when you take out too much CSF and the brain looks like very swollen. Although there is no pressure, but it looks like swollen. So what we do right now is after the CSF starts clearing, we put the bag on 10 centimeter height so that we prevent over drainage. So this is one thing that we do. Well, other than that, I really, these are the major ones that I can think of. Otherwise, other than vascular infections and this over drainage, I really cannot think about any other as complications related to the procedure as such.
Oh, okay, thank you, Professor. Aquí tenemos también a la profesora Silvia Sarva. Profesora, ¿quiere hacer algún comentario? Un placer tenerla con nosotros acá. Parece que la profesora no tiene en estos momentos conexión. ¿Alguien más que quiera hacer alguna otra?
How you doing? You've been here a long time and given a lot of your free time up. We don't want to keep you here all night.
Yeah, so my entire team is here. Let me just introduce you guys, please. I would like to introduce my team here. Hari is the person who talked to you regarding this. He's my consultant. And then we have Sajiv. Sajiv is also my senior consultant. He also does cystostomies quite often now. And then we have Dr. Tamerlan, who is in charge of our lab. He's from Russia. And we have an Esculap Academy lab, so it's very important for us to keep on doing these courses. We have one on 12th and 13th, the endoscopic course, and then we have Edmundo Valencia from Peru. So yeah, so he is also with us.
Mucho españoles.
Yes, yes, of course, he can understand. He's our Spanish go-to guy. So I'm very happy to introduce all of them. We also have Nargisa, but Nargisa she's not well. She has probably some fever or something. And we have Giacomo also, who has just gone back home. Giacomo is from Italy. So we have a good team here. So we have skull base and vascular as my specialty, and Sajiv does the spine part. And all the fellows who come here, they learn all this. And Manuel has been with us for some time. We expect many more youngsters to come here, and so that we can exchange information with them. And we hope to work with people from all over the world, so that truly one world, one neurosurgery can be realized.
Mikhail wants the email address of Eugenio. Eugenio from Venezuela was there. So Mikhail's asking for Eugenio's email address.
I can give him the WhatsApp number for Eugenio if that is okay. I don't know about
Yeah,
Eugenio.
that would be fine. You're there, Mikhail, right?
Yes, Eugenio, the number would be, can I tell you the number?
You're there, Mikhail, right? Well, just write it in. Can you write it in the chat there or WhatsApp, whatever?
Yes, so I'm sending it to the hosts and panelists. It is a 0058.
Yeah, it'd be nice if you could talk to someone in the same country about cystinostomy. And Marco, it sounds like you're going to India.
Well, I would like to go one day there and learn from Professor Ipe, because it will be an honor, a great honor to do it. Because
You could go there a couple of months.
You're most welcome.
Yeah, because it's an incredible work, and there are a lot of things going on with this cystinostomy, because it's changing the whole perspective that the neurosurgery had all the way long until these techniques start coming up.
Go for it.
Yeah, hopefully it would do.
You are most welcome.
Yeah, and also here we have a lot of people from Latin America hearing Professor Shiri, and that's the other reason why everyone is making a lot of questions, because this is the first time we have the option to have you here, and this platform is giving us the opportunity to have you and asking all these questions, because it's a really incredible work you're doing, sir, to be honest.
Okay.
I hope to see you sometime.
Okay, is there any more questions or comments before we close?
Tenemos al profesor Duniel Abreu, que creo que quería hacer una pregunta. Profesor Duniel, se encuentra ahí el profesor neurocirujano del Instituto de Neurología y Neurocirugía de Cuba, donde me formé, y mi profesor, mi amigo, y un placer para mí tenerlo acá, profesor.
Oh, es primera vez que me sumo a esto, majestuoso, fenomenal. Es la primera vez que participo y me da un placer ver que hay de todos lados, pero hay muchos cubanos. Ahí está Suren, la doctora Silvia Sabba, estás tú, estoy yo. Hasta Micael lo vi por ahí, y yo no voy a hacer ninguna pregunta técnica. Como ven, estoy en la cocina haciendo de todo, pero no quería pasar el momento por saludar a todos esos encumbrados profesores que hacen posiblemente esto. A ti por este acercamiento. Qué bueno ver a Suren, que no lo conozco personalmente, pero sí de las redes, y además como un neurocirujano bien nombrado aquí en La Habana. Un saludo, y en algún momento estaré compartiendo un poco más desde el punto de vista científico, pero esta era mi primera incursión. Tuviste que darme un mínimo técnico ahí de Zoom y todo el avatar de la tecnología, pero nada, ya rompí el hielo y aquí estamos. Y quizás el próximo domingo, más adelante, estaremos hablando de algo más serio. Gracias, y para mí todo un placer saber que hay cubanos donde quiera. Y ahí, vaya, qué placer ver a la doctora ahí, que Silvia Sabba, y al mismo Suren, y decir, pues Dios mío, cubanos vemos donde quiera. Yo estoy en La Habana, pero al final todos estamos rodeados de 4 letras y haciendo neurocirugía por el bien de nuestros pacientes, donde quiera que estemos. Qué bueno, gracias por esta oportunidad y por esta idea.
Muchas gracias, profesor. Muchas gracias, Pam. Nosotros es un placer.
Saludos,
y estamos haciendo todo lo posible por la semana que viene tener una ronda de cirugía espinal con el profesor Duniel, y vamos a ver si podemos
vamos a ver
sumar.
Si convencemos a Norberi también para que se sume a esto.
Anótame ahí también. Anótame ahí por una plática ahí de columna.
Sí. Vamos a ver si podemos llevarla a cabo. Estamos intentando organizarla. John, I think that the morning has been more than amazing, to be honest.
I thought you can tell the people really wanted to hear you, really wanted to see you, and I'm sure there's a lot more. So thanks everyone for putting it together, and thanks for your participation. Thanks for your time, Mike, Zurin, Victor, Marco, manual, especially for your interpretation. I think it worked a little bit. We had some Spanish questions. We'll get better with it. So, okay, we'll keep in touch. We'll be doing more shows. Thank you.
Thank you, guys.
You.
I see that Fawad Prasad is also here. Thank you very much, friend. Long time.
Thank you, Professor. Thank you, everyone, for being here with us today. It's been really an